Okay, good afternoon. Thanks for being here during lunchtime. So, uveitic causes of visual loss in children. Uh, Uveitis is a potentially blinding disease. Why? Because children usually do not complain, and the signs and symptoms of the uveitis in children are very subtle, and even the parents don't recognize it. And when they come to us, they usually come to us quite late, and because of the severe complications of the disease. So I have just roughly classified the uveitic causes into non-infectious and infectious causes. JIA or juvenile idiopathic arthritis still remains the most common cause of non-infectious uveitis in children. In infectious causes, we have toxoplasma as the commonest cause worldwide, but in an endemic country like India, ocular TB is also equally important. So let's move on to juvenile idiopathic arthritis. I'll dwell on this a little bit longer because it's quite common in children, and it causes non-granulomatous anterior uveitis. It can be unilateral or bilateral, and if it is bilateral, it is usually bilaterally asymmetrical. The joints involved are usually the large joints, the knees and the ankle can be involved, and they usually come to us with these complications like BSK or secondary glaucoma, cataract, and sometimes if the inflammation is not well controlled, they can have intractable cystoid macular edema, hypotony because of ciliary body atrophy, ciliary body detachment, and cyclitic membrane formation. Okay? So we need guidelines for uveitis. So high-risk patients are those who are ANA positive, who have onset of arthritis at below 6 years of age, and who have less than 4 months, 4 joints involved. And so these patients need to be followed up every 3 months. Moderate risk patients who are ANA negative can be followed up every 6 months. Then you have low risk patients where they have arthritis with systemic involvement like fever, hepatosplenomegaly, malaise. So treatment guidelines, you need to just, because it's an anterior uveitis, treat them with topical steroids, continue it for at least 3 months. If they do not respond, add steroids and immunosuppressive. Again, if the response is poor, add biologicals. If you're going for surgery, ensure 3 months of complete quiescence before you go for surgery. And you need to follow up the patient very frequently, even after surgery, for inflammation. Continue medical therapy till 2 years of quiescence. This is another syndrome, Blow syndrome, which again presents with arthritis and uveitis, but it's different from JIA because it's usually granulomatous, and here the small joints are involved, and you have severe deformity of the joints, and the ocular cause, it can cause present as anterior uveitis, panuveitis, and even have present with corneal scars. The cause of poor visual outcome in these patients is secondary glaucoma, even hypotony because of cyclitic membrane formation. So they need aggressive treatment with steroids and immunosuppressives. VKH can also occur in childhood. We had this 11-year-old boy who presented with defective vision in both eyes. You can see the hyperemic disc and the serous detachments in the fundus as well as the OCT. And he was treated with steroids and immunosuppressive, but he needed adalimumab injection for complete resolution. In VKH, you need to follow up the patients very carefully for chronic CME, subretinal fibrosis, CNVM, which can cause poor visual outcome. Behçet's disease is a systemic vasculitis, but it can cause vasculitis in the eye as well. But this 15-year-old patient presented to us with floaters, and she had history of oral ulcers. Even though the fundus was clinically normal, but when we did an FFA, we found the characteristic fern pattern capillary leak. And these patients with Behçet's lose their vision because of vasculitis and optic atrophy, peripheral vascular NVE formation, vitreous hemorrhage, and retinal detachments. Pars planitis is an idiopathic subset of intermediate uveitis, can present with snowballs, snow banking. Anterior segment is usually quiet, just a few spillover cells. Cause of vision drop is usually intractable CME, and sometimes the peripheral vasculitis may be there, which can result in a new vessel formation and retinal detachment, vitreous hemorrhage as a cause for poor vision. Do not forget the masquerades, because by diagnosing a masquerade early, you can save the eye as well as the life of the patient. So we had this patient who was on treatment for acute lymphoblastic leukemia, and he presented to us with a hypopyon, and we did an AC tap, and it showed malignant cells. And patient chemotherapy was intensified, and it saw after local therapy the hypopyon resolved. So let's move on now to the infectious causes. Toxoplasmosis, as you know, is the commonest cause of infectious posterior uveitis. It can be congenital or acquired. Congenital toxoplasmosis occurs when the mother has an active infection during pregnancy. So child can be born with telltale signs of systemic toxoplasmosis, or the child may look normal, or the child may have a macular lesion like this. You can also have the acquired toxoplasmosis in children, like in this child who came with a retinochoroiditis patch near the macula. You can see the adjacent scar and the Chiarides arteritis. So on recovery of the infection, the child will have definitely a scar, but active treatment can reduce the size of the scar. Toxo lesions can also be seen peripherally, which usually they heal without sequelae. Sometimes there can be visual loss, can be because of a macular drag. Other causes of poor vision in patients with toxo are CNVM and retinal detachment. Toxocara is a nematode worm which is found in dogs, and it can cause posterior pole granuloma. It can cause a peripheral granuloma with traction bands extending from the granuloma to the disc as well as the macula. And when it heals with sequelae like vitreous membranes and opaque vitreous, which is also responsible for the poor vision in such patients. Active lesions like this can be treated with albendazole as well as oral steroids, but most of them may require surgery to remove the ERM or the vitreous opacities and for the retinal detachment. DUSN is usually unilateral. If they come to us early, this is the ocular picture with hyperemic disc and track lesions. So your course of albendazole with steroids can cure the disease. But in case they do come to us late, this would be the clinical picture in the eye with optic atrophy and thinning of the inner and outer retinal layers. Even though mumps is a benign condition, of late we have been seeing patients with who develop defective vision in both eyes, poor vision in both eyes after an episode of mumps. So this is a case of cerebriform retinitis post-mumps. It caused complete necrosis of the inner and outer retinal layer. We were able to salvage some amount of vision in this patient with steroids and hyperbaric oxygen therapy. Trematode is a larva which is found in the waters of certain rivers, especially the Kaveri River, and children swimming in these waters get the infection through direct infection of the conjunctiva by the larva. So it can cause granulomas in the conjunctiva. It can cause an AC granuloma. Usually the outcome is good with steroids, but some of them do, if you don't diagnose it early, can cause retrocorneal membrane and a complicated cataract. Now don't forget ocular tuberculosis in an endemic country like ours. So this patient had a choroiditis lesion very close to the macula. You can see the vasculitis as well, and her MANTO was positive. Her CT chest showed evidence of old TB. And you can see the OCT showing an RP elevation in the contact sign. And after starting ATT, there was complete resolution of the lesion. So early recognition and timely management of the disease and its complications can preserve vision in a child. Thank you.
Thank you, Dr. Radhika. That was an excellent presentation. I have one question. Is like when we operate for cataract, pediatric cataract in JRAs with, we put an intraocular lens, and then we find that the inflammation, there's so much recurrence of inflammation even after 1 year. So how long do we have to give the immunosuppressive therapy? Because I find the uveitic specialists keeping on giving the immunosuppressive therapy, and sometimes it is for 3 years or 4 years.
Yes.
So
they have to be continued for a very long time, ma'am. Even we need to have 2 years of quiescence, as I mentioned in my talk, 2 years of quiescence before you can even think of stopping the medications. So, and soon after a cataract surgery, patients can develop inflammation off and on. Therefore, they have to be followed up very carefully. even in the post-op period. And you do not stop the immunosuppressive or the corticosteroids prior to surgery. You just continue it.
So the parents keep asking, when will
Yes.
it stop? So it won't stop.
It won't stop till the child achieves 2 years of quiescence. Yeah, you will have to
Okay.
convey that message to them.
Okay. So